Next, I want to discuss neurological injuries and neurological emergencies for step 2. Let's take head trauma, a very, very common problem, and there will be a couple questions on the management of minor and severe head trauma on the exam. So the head trauma case is going to be blunt head trauma. That means there's no open skull fracture, blunt head trauma. It's a car accident, it's a fall. And it's going to be someone, and they're going to have some type of accident. It's going to be a sports injury or a fall or an automobile accident. Patient bumps the head. Okay? They're going to tell you that there's an ecchymosis or a bruise or a contusion or a laceration around the scalp. Okay? He feels a little nauseated. He hasn't vomited. And then they're going to tell you the key issue, what you're looking for. They're going to tell you if he has or has not lost consciousness, if the patient got knocked out or didn't. Okay? And this is something that I'm really looking for. I'm not that concerned about the ecchymosis and contusion and laceration. If it's a cut, I'm going to fix it. If it's an ecchymosis or contusion, they can have a little ice for it. The key issue is that the patient get knocked out or not. If the patient had loss of consciousness, they need neuroimaging. That's what I'm looking for. I also am quite interested in the fact if the patient has focal neurological deficits or not. If the patient's suddenly weak on one side of the body and he wasn't before, then I'm most assured that he has a significant intracerebral hemorrhage. Whether or not he signed the organ donation card at this stage is irrelevant. Right now we're focusing on doing everything we can for this patient. All right? Does he need a head scan if you lost consciousness? The answer is yes. So here's the equation. LOC equals head CT. How's that? Remember that. Does he need CT with contrast or CT plain? The answer is he needs CT plain. CT plain shows acute hemorrhage from the trauma. CT of the head with contrast, that's to look for tumor. Okay, that's to look for an abscess. For trauma, looking for blood, plain. Next, the other distractor will be, should we do an MRI for acute head trauma? Acute means I just bumped it now, right? And the answer for that is no. CAT scan is better. MRI is better to detect acute ischemia. CT is better to detect acute hemorrhage. And that's how you remember that. All right? Does he need a skull x-ray? Skull x-rays are kind of obsolete. On the CAT scan, you see the bone windows, and you can tell if there's a skull fracture there now. So skull x-rays have kind of mostly disappeared from commonly ordered tests. Right? Does he need a neck x-ray? You know, anyone that has a significant head injury or injury above the clavicles, you have to be concerned that they may have other injuries, including a fractured neck. So this patient may very well need C-spine imaging as well. And of course, if there's just head trauma, there might be trauma somewhere else, so he needs a complete physical exam and search for other kinds of occult trauma that aren't readily apparent. Now, there's 4 types of diagnoses which you'll get after this, we know that this person hit their head and passed out. It's either going to be a concussion, cerebral concussion. It's going to be a contusion, a cerebral contusion, or it's going to be a subdural hematoma or an epidural hematoma. This accounts for the vast majority, all of the cases of head trauma. All right? We're going to talk a little bit about subarachnoid hemorrhage too, but I want you to know right now that subarachnoid hemorrhage is usually a medical condition. Subarachnoid hemorrhage is not usually from trauma. Subarachnoid hemorrhage is from a congenital weakness in the blood vessels at the base of the brain that spontaneously ruptures and causes symptoms. Okay? Subarachnoid hemorrhage looks more like meningitis. I suddenly had this bad headache with photophobia and stiff neck, maybe even fever. Okay? So we're going to consider concussion, contusion, subdural, and epidural now. A concussion, you make the diagnosis by finding out that the patient had loss of consciousness at the time of injury and they have a normal CAT scan. The diagnosis is LOC plus normal CAT scan. There's no blood in the head. All right? If you got a perfectly normal CAT scan, what do you do with the patient? Can they go home or can they stay in the hospital? If they have reliable family, they can go home and be observed for the next day. If they're all alone in town and they have no one to watch them, then they would need to be admitted and observed because there's no one to watch them and do neuro checks on them. How often do you do neuro checks? 3 hours is not an absolute hard rule. 4 hours is okay at home. But you want someone to keep an eye on the patient, so if they do suddenly have a problem and become unresponsive, there's someone there to call the ambulance, right? Okay. See the patient back in a week, see the patient back in a week after that, and a month after that, until they're back to normal. Because many patients, even with normal CAT scans with loss of consciousness, concussion, they have what's called post-concussive syndrome, and this can manifest as a change in personality, a change in their level of functioning that lasts for months. They may need counseling and rehabilitation even from a seemingly minor concussion. And the other important thing is don't get hit in the head again. Try not to get concussed a second time, right? What is a cerebral contusion? A cerebral contusion, well, contusion means bruise. So if there's bruised brain, you have a cerebral contusion. And that's going to show little patchy areas of hemorrhage throughout the parenchyma of the brain. And there might be some edema that develops over the next 2 or 3 days. Anyone that has acute bleeding in the brain, they stay in the hospital. All right? All right? How are you going to treat a contusion? Most contusions never get any worse, and most contusions do not need neurosurgery to drain them. However, if you're admitting someone to the hospital for a cerebral contusion, you are wise, for the patient's benefit, to let the neurosurgeon know that the patient's there. That way, if the patient deteriorates, the surgeon will be rapid to respond to the patient's needs. Of course, you could do the simple things to decrease intracerebral hemorrhage on these type of patients with relatively minor head trauma, as well as patients with the most massive head trauma. All of them, if you elevate the head of the bed, you're doing a good job. You're decreasing the intracerebral pressure a little bit. You don't want these patients straining at stool, so stool softeners are appropriate as well. Patients with cerebral contusion, you certainly don't want to give aspirin to or Coumadin to or heparin to or any additional blood thinners. They already got a little bit of bleeding in the brain. Be sure to check the platelet count on these patients. Be sure to check the coag panel, the INR on these patients. You want to make sure they're not at risk for continued hemorrhage. Subdural hematomas are usually venous in origin. They may be acute or chronic. Depending on the size of the subdural hematoma and the rate of accumulation, they can be fatal very quickly, within minutes to hours after a head trauma, or they can persist for months to years without being detected. Elderly patients are famous for having subdural hematomas that are chronic in nature, that slowly accumulate over the course of days to weeks, and are a common cause of dementia in the elderly. Looking for chronic subdural hematoma is part of every altered mental status workup, especially in patients over the age of 65. These patients with chronic subdural may not even remember the accident that initiated the bleeding in the brain. Okay. Here's a picture of a subdural, and it shows the crescent-shaped general shape of the hemorrhage. This is an acute subdural here. With acute hemorrhage, the blood appears white on the CAT scan. Here is a picture of an epidural hematoma. These are usually arterial in nature. They're often associated with a skull fracture on the side of the head with a tear of the middle meningeal artery. In this picture here, we see the typical lens shape of an epidural hematoma. This particular X-ray has a big scalp hematoma outside of the skull as well, which is interesting to look at. Epidural and subdural hematomas that are acute often need surgical drainage. If the patient has a decreasing level of consciousness, a decreasing Glasgow Coma Scale, the neurosurgeon needs to be involved. A common misperception is that the epidural is worse than the subdural hematoma. And the reality of the situation is the bleeding that's worse is the one that's larger, that causes more pressure on the brain. There are people that have little tiny epidural hematomas that don't cause much symptoms. And there are people with acute, huge subdural hematomas causing massive midline shift and herniation. So what is worse, subdural or epidural? It depends on how much bleeding's in the brain. The Glasgow Coma Scale is a good thing. When I say someone's comatose or stuporous or lethargic, that means something different between individual physicians. So if we use the Glasgow Coma Scale, we could all be speaking the same language, and we can communicate one person to the next the level of severity of the brain injury. That's its purpose. We could also do the Glasgow Coma Scale serially over the course of the patient's admission. So if the scale is decreasing, that's a worse sign that the patient might be having continued bleeding in the brain. It's a 15-point scale. It's the best verbal response, the best eye-opening response, and the best motor response. All right? The verbal response is a 5-point scale. You get 5 points if you're alert and oriented. You get 4 points if you're conversational and talking, but slightly confused. Okay? Okay? You get 3 points if you're talking, but the words are inappropriate. But you could still make out the individual words are enunciated. You get 2 points for mumbling. Right? That's 2 points. And you get 1 point for having a mouth. All right? 1 point's the worst. Spontaneous eye opening, you get 4 points. For eye opening, the scale is to 4 points. You get 4 points for spontaneously opening your eyes. Right? You get 3 points if your eyes are always closed, but if someone calls your name, hey, Dr. Phil, your eyes open. That's 3 points. You get 2 points if your eyes remain closed to the calling of your name, but you open your eyes if someone does something painful to you, like starting an IV. So if the patient only opens the eyes when the IV is started, that's 2 points. And you get 1 point even if there's no eye opening at all. The best motor response, you get 6 points for obeying commands. All right? You get 5 points if your best response is purposeful movement to painful stimulus. So in other words, if the patient tries to pull out the IV that the nurse started, that's 5 points. If the patient's best response is withdrawal with response to pain, that's 4. An example would be the IV is started and the patient doesn't try to pull it out, but he just tries to move his whole arm away. All right? What is decorticate posturing? These patients are usually nonverbal. They are asleep. Decorticate posturing is when the patient's arms are flexed like this. I remember this because the hands are pointed to the cortex. The cortex is not working. Decorticate, not a good sign. Decerebrate is worse. Decerebrate posturing. Okay? And even if you're just completely flaccid, you get 1 point. So the scale is from 3 to 15, right? People with severe head injury, that's defined as a Glasgow scale less than 8, that's really severe. Most of these patients are going to end up intubated on the ventilator and in the intensive care unit with the severe head injury. Moderate is 9 to 12, mild is 13 to 15. These numbers aren't so important, only to realize that the lower the score, the worse off you are. And if your score is decreasing, that's not a good sign. So let's talk about those severely injured head patients. What special treatment do they get? First of all, many of these people do end up having the epidural or subdural bleeding, subdural hemorrhage, and will need surgery to decompress the pressure on their brain. Okay? We talked this morning or earlier, steroids are not indicated for brain trauma. Period. They don't work. Steroids are wonderful for swelling in the brain caused by tumor or cancer, but not trauma. Mannitol, when is mannitol used with severe head injury? Mannitol will shrink the normal brain tissue. It does not shrink the size of the blood clot in the skull. But by shrinking the normal brain tissue, you may decrease the intracranial pressure slightly. And this is sometimes used while you are waiting for the neurosurgeon to take the patient to the operating room to remove the blood clot, to remove the drain the subdural or drain the epidural hematoma. That is the purpose for mannitol. Okay? If the Glasgow Coma Scale is low, you will ventilate and the patient, and you'll keep their PCO2 about 30-35. We do not hyperventilate the patient down to very low PCO2 levels because that actually increases the intracranial pressure. All right? I would not check Doll's eyes on these patients. Why? Because you have to move the neck and you still don't know for sure if the patient has a fracture of the neck or not. Another technique the neurosurgeon might do is to put an intracerebral pressure monitor, and if high, you can remove a little bit of the cerebral spinal fluid, thus lowering the pressure inside the skull. We also already talked about barbiturate coma is useful in severe head trauma. We talked about toxicology. So that might be a useful treatment as well. So people with severe head trauma, what type of blood pressure range do you want? You'd like to keep the systolic blood pressure a little bit on the high side, between 160 and 110. Why? Why? Why is a little higher blood pressure better than a little lower blood pressure with severe head trauma? It's because the cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. So if your mean arterial pressure drops, your cerebral perfusion pressure can go very, very low, thus adding an ischemic stroke from lack of blood flow to the brain tissue on top of the blood from the subdural or epidural.